specialise in the removal of compacted earwax, infected debris and discharge from the ear canal. We have a client here who attended with otitis externa, and more specifically he has otomycosis, which is a fungal infection, and that's normally categorised by fungal spores, which hopefully you saw on that pre-examination video. So otitis externa is an umbrella term given to an ear infection or inflammation of the outer ear canal. And the otomycosis, you can see there where I'm just approaching it with the suction probe, it almost has a cotton wool appearance, but if you look very closely, you'll see little fungal spores. So he has here a thick layer of keratin that's coating the ear canal, and also it's impacted on the eardrum itself. So I'm just using a fine end gauge here to gently lift this thickened keratin off the canal wall, which will help me later peel it. At the base of the ear canal, as you can see, I'm just gently lifting this dead skin, and as I'm lifting it, you can see there's a moist undercoat. That moist undercoat is where the skin itself, the dead keratin, is attached to the ear canal wall, and there's a bit of humidity there, moisture, sweat, which causes it to be a bit damp. I didn't use the standard size on the suction probe straight away because he has got a slightly narrow ear canal. And with the fine end, I do find it's better to use a fine end when we're trying to peel dead skin off the ear canal wall. It's a narrower tip which provides me with more precision, and it's also less atraumatic. So if we do come in contact with the ear canal wall, it's far less uncomfortable for the client. I'm just there tugging away more superiorly, so at the top of the ear canal. There is this dead keratin that's lodged within the anterior recess, and you'll be able to better see that in a moment. You may have noticed now I've reverted back to the standards on the suction probe. This keratin is very thick and it's lodged beyond his isthmus, which is a narrowing of the ear canal adjacent to the eardrum. And beyond the isthmus, the ear canal then widens again. You can see here where I am with the suction probe, it almost looks as though the client has been using Q-tips or cotton buds. There's a bit of a woolly appearance on the surface of the dead skin. So I'm on the posterior canal wall, and what I'm trying to achieve here is just loosen this skin, this kind of embedded keratin, all the way around the ear canal wall. And again, I'm just working superiorly there, and you can see it's finally becoming looser. I've got a small piece of keratin out there. The patient himself is guilty as charged, really. He tried to remove the blockage using one of these over the internet, over the counter earwax removal scoops, and he instead managed to really impact this against his eardrum. In cases like this where you've got a bit of dead keratin or skin, you could sometimes use a bit of sodium bicarbonate earwax drops, which helps loosen dead keratin and skin. However, because the client's ear is already infected, you just want to avoid any other moisture or drops being inserted into the ear canal. So I've removed a large plug of dead keratin there, and you can see there's an infected layer of dead keratin that's right on his eardrum. So I've had to go back in with a fine end gauge here, and if this keratin was a thin layer, as soon as you hover over it, it just kind of loses its grip against the eardrum, comes up immediately. But this layer of keratin is a bit thick, and it's also a bit more sticky and soft. What we're almost trying to do is peel off a piece of sellotape that's been on some paper. The eardrum itself, the thickness is equivalent to a thin sheet of paper, and you can just kind of compare this embedded dead skin to being a piece of sellotape, and you just have to gently peel this off without causing any injury or trauma to the eardrum. What I've done, I've actually bent the distal end of the fine end gauge just to enter and obtain access into the anterior recess here, and I'm just gently trying to peel it from this region. If you generally wax and dead skin, it's always, if it's near the eardrum, it's almost often, in any case, hidden away in this anterior recess. And if you can loosen this region, it makes the procedure a lot easier. And you can see there we're just gently peeling and tugging this dead skin off the eardrum, slowly revealing it. The patient is not feeling any discomfort whatsoever. And there's that thick layer of keratin that was coating the eardrum. There's a full view of the eardrum there. It doesn't look like a normal healthy eardrum. It's dull. You can't see the light reflex. You can't really establish where the handle of malleus is, which is the hammer bone. Sometimes with an eardrum with that appearance, it could be that they've also got otitis media with effusion, which is a middle ear infection. It can also be called acute otitis media with effusion. Commonly, it's more recognised as being called glue ear. However, I did do a pressure test called tympanometry, which assesses the mobility of the eardrum and the middle ear bones. And the client had normal mobility of his middle ear, which completely rules out possible otitis media. Instead, that appearance is due to the otitis externa. The otitis externa not only can cause an infection of the ear canal, the skin that lines the ear canal, and the underlying cartilage and bone, but it can also affect the outer layer of the eardrum. So the procedure itself is complete, but I'm just trying to mop up and peel off as much as skin as possible now. It's just not possible for us to get every little speck out. We'll be here all day. You can imagine how tedious that would be. And a lot of this dead skin, as I said, he has got otitis externa, so it's almost like an eczema of the ear. It is quite superficial, it's not acute. If it was acute, you'll also get a lot of inflammation of the ear canal wall. And the patient has been referred to their GP for prescription of some ear spray to help with that otitis externa. Again, I'm just trying to remove some of the lateral wax here. There's some wax there just at the entrance. When you enter the ear canal, there is a slight blind spot just as you enter on the left hand side for the right ear. And if it's the left ear, you get the same blind spot just as you enter, but on the right hand side. And again, just a bit of soft keratin just at the roof of the ear canal. That's a sensitive region of the ear canal. So the outer third is composed of cartilage and fatty tissue, and the inner 2/3 of the ear canal is quite simply a very thin layer of skin coating the bony part of the ear canal. And if you do make contact with that bony part, it can be very uncomfortable for the patient. And that's just a close-up, a zoomed-in view of the eardrum. I hope you enjoyed watching that video, guys, and if this is the first time you've watched one of my videos on YouTube, please do subscribe, like the video, leave a comment, and be sure to select the bell icon so you get notified as and when I upload new videos. And similarly, if you're watching on Facebook, do follow the page, like the video too, and feel free to leave a comment. I hope